Hello, everyone. And while we are waiting for others to join, um, put in the chat box, if you will, where you're from, just the city where you're from, so I know who you are and where you are. Well, from what I'm seeing, we have representation from each region in the country, which is good. Thank you. Okay, we're a little bit past 5:30, and we're gonna just go ahead and get started. Hello, everyone, and thank you so much for joining today. My name is Catherine Blackwell, and I am the Chief Health Equity Officer for Allergy and Asthma Network. Welcome to the Black People Like Me virtual conference series, which addresses ongoing disparities and barriers to care for the Black community living with asthma, allergies, and related conditions. We have a few housekeeping items before we start today's program. First, all of you will be muted for the webinar. We're going to record today's presentation and post it on our website within a few days. The presentation will be about an hour, and that includes time for questions. And we're going to take those questions at the end of the webinar, but you can put your questions in the Q&A box at any time, and that Q&A box is located at the bottom of your screen there. We have someone monitoring the chat, so if you have questions or need help, you can certainly put them in there. We're going to get to as many questions as we can before we conclude today's webinar. We're not going to be offering continuing education credits for this webinar, but we do have a certificate of attendance if you need one for your records. A few days after the webinar, you're going to receive an email with supplemental information and a link to download the certificate of attendance. So let's get started. Today's presentation is called Addressing Barriers in Food Allergies and Empowering the Black Community. First, we'll have Dr. Nancy Joseph talk about food allergies, how they're diagnosed, how they are treated, and some barriers to care for the Black community. Then we'll have Thomas Silvera. He's going to talk about his experience with food allergies. I'm going to talk a little bit about clinical trials and the importance of diverse representation in research. And finally, we'll answer some questions from the audience. Special thanks to Genentech, who has provided funding support to make this presentation possible today. Thank you so much for that. So it is my pleasure to introduce our first speaker, Dr. Nancy Joseph. Dr. Joseph is double board certified in general pediatrics and allergy immunology and is currently based in Massachusetts. She is a consultant and medical advisor for the Allergy and Asthma Network. Dr. Joseph is a member and fellow of the American College of Allergy, Asthma, and Immunology and the National Medical Association, NMA for short, in which she is actively locally and nationally. She has collaborated with the NAACP, speaking about COVID-19 during the height of the pandemic, and has been featured on NMA Talks as an expert panelist discussing asthma, excuse me, in the African-American community. Dr. Joseph has been awarded Top Physician Under 40 by the NMA. She also hosts the How Do You Medicine podcast, highlighting healthcare professionals doing medicine their way. Thank you so much for being here today, Dr. Joseph. I'll turn it over to you.
Thank you so much, Catherine. I really appreciate it. Thanks for the introduction. Hello, everyone. Go ahead and put your questions in the chat and we'll answer it later, but I'll go ahead and start my presentation. So first we'll talk about where we're gonna go, and then we'll get into the meat and potatoes of the presentation. So the roadmap here is not quite as windy as this road in the picture, but we're really gonna start with some stats and basics, jump into disparities, which is the important and the meat and potatoes of this presentation, talk about the burdens of food allergy versus other adverse food reactions. We'll talk about treatment and some really helpful resources in combating food allergy from various aspects. So first, let's start off with some stats. So you'll notice that 19% of adults in the United States have believed that they have food allergy, but only 10% of those adults are actually been confirmed to have food allergy. So there's a difference or disparities in that, really showcasing that, hey, it's really important for you to, if you have a suspicion of food allergy, to go ahead and get that, confirmed and get that evaluated. And when we talk about children, 1 in 12 children in the US has a food allergy. So just the topic of food allergy in itself is a very important one just by looking at the numbers alone. Let's really talk about food allergy in the Black community then. After all, that's why we're here. So food allergy in the Black community, when we really want to talk about numbers in terms of disparities, African Americans have 4 times more frequent diagnosis of food allergy than their white counterparts. And African Americans have a higher rate of death from food allergies. In addition to that, they have a higher level of a cell called IgE, well, various allergy cells, including a cell called IgE. We'll talk more about what IgE is and what it means later, but just take note that there's a lot of allergy cells that are in higher levels than African Americans in general. Now let's talk about African American children. So African American children have a peanut allergy that's present at 8 times higher rate than their white counterparts. And they have a higher rate of allergy to corn, shellfish, and fish. And they have 3 times a higher chance of having a shellfish allergy. They're more likely to have multiple food allergies, and African American children with allergic diseases or parental history of any allergic disease, where we're talking about asthma, environmental allergens, or food allergy. Just having that history of allergic disease or a parent with an allergic disease puts you at higher chance of having a shellfish allergy in general. So let's talk a little bit more about genetics. So there's not much in the way of genetics in terms of um, you know, data out there, just because more studies are needed. But out of the data that is out there now, though scant, they did find that some genetic variants occur more frequently in African Americans. But like I said, more studies are needed because there's a lack of diversity in clinical trials. We'll talk more about clinical trials specifically later, but there's a lack of diversity in it such that European Americans are referenced in food allergy literature 5 times more than African Americans. And access to care plays a very important role in that. There is a wonderful study by Dr. Carla Davis called the Forward Study that's really helping combat this, but more research is really needed. But because the Forward Study is really such a wonderful study, really helping with this, I wanted to go ahead and touch on it a little bit. And excuse me in advance, I'm getting over a cold, so if I do a little coughing, please bear with me. So the Forward Study is a multi-centered study, 3 centers, 4 cities. I'm sorry, 4 centers, 3 cities, that these participants were children between the ages of 0 and 12 years of age, and it was 644 children total. So with this study, they found that African Americans had 3 times higher chance of having shellfish allergy. They had 2.5 times higher chance of having finfish allergy. And in less than 50% of these African American children had confirmatory testing for their food allergy, or was even evaluated by an allergist. And then there's a higher rate of food-related anaphylaxis and ER visits in African Americans. So clearly there's a lack of access there. There's a lack of anticipatory guidance there. But we'll get more into that a little bit later. So let's really talk about that. We talked about lack of diversity in research and studies. Well, the Allergy Asthma Network really wants to make sure you know that, hey, you can make your voice heard, and you can help combat these disparities. First, there's multiple ways to get involved, right? If you don't really want to get involved in clinical trials, there's ways to maybe just like dip your baby toe in when it comes to these research. First, you can, you can join a patient advisory group, participate in a disease registry, participate in focus groups. You can participate in surveys. Even the Allergy Asthma Network website has ways that you can get involved, and this is what the screen would look like. And you could click on it and it show you current opportunities to get involved with research, and you can see which one you're more comfortable with and, get started. But either way, your voice is important. So at least getting involved in some way will be helpful. So let's get into the burdens of food allergy, the weight of it all, I like to call it. So food allergy has multiple burdens. We'll talk about economic burdens, quality of life burdens, and mental health burdens. Let's start with economics. So first, food allergies actually cost US families $25 billion a year. And allergy-friendly foods, as you can imagine, cost 30% more than any other foods. And when we talk about quality of life, there's a decrease in quality of life for people with food allergies to the point that some people even qualify for disability. In addition, there's social restrictions, right? You can lead to avoidance of restaurants, restricted in social activity or travel. You can even get like over 50% of adults with food allergies have a severe reaction. So you can see how that can lead to avoidance of certain situations. Now jumping into children, now over 40% of children with food allergies have had a severe reaction, and their children with food allergies are twice as likely to be bullied. And one in three children with food allergies has said that they've been bullied specifically for their food allergies, and they have an increased incidence of anxiety and panic attacks. Mothers of food allergic preschoolers were found to have higher blood pressures and increased stress. Excuse me. So then let's talk about the mental health aspects and the burdens of food allergy. Well, FARE is an organization we'll talk about more later. They have a registry, and that registry was used to conduct some research, and that particular research involved over 1,600 patients. And out of that, they found that 54% expressed feelings of anxiety, 32% expressed feelings of panic, and they noticed if the person had more than one reaction per year, that increased the chance of having food-related mental health concern, like a food-related anxiety, something like that. So individuals with food allergy do have the tendency to have, food allergy related anxiety, which, rightly so, right? That makes sense if you've had a history of having anaphylaxis and needing to get an EpiPen, being rushed to the emergency room. That can increase your chance of having that food related anxiety. Now let's jump into the mental health burdens of caregivers of allergic patients, right? Caregivers of allergic patients are found to have increased levels of anxiety and depression as well. Now, one study even showed that 45% of caregivers don't even think their child is safe at school. Just think about that for a second. Your child's at school most of the day, and 45%, almost 50%, almost half of caregivers don't even think their children is safe there because of their food allergy. So now let's talk about food allergy then, in its purest form, its definition, and then we'll jump into adverse food reactions. So I like to call this my major key. Now I'll talk about some other keys later, but if you don't remember anything else, remember this major key. When we talk about the food allergies versus adverse food reactions, there are a number of adverse food reactions that are not allergic in nature. So we'll talk about what an adverse food reaction is and how it relates to food allergy. So food allergy versus food intolerance is what we'll start off with. So food allergy, really what it is an adverse food reaction. Adverse food reaction just means something uncomfortable that happens with food, but it doesn't always have to be allergic. Food allergy specifically is driven by a cell called IgE. That's important because there are tests out there that use IgG. Don't buy those tests. Don't use those tests for allergic purposes. That is not related to allergy, because allergy cell is the IgE. So it's not an allergy cell, IgG. So don't get those over the counter or those online tests. They're not helpful to help shed a light on your food allergy at all. Food allergy tends to occur secondary to exposure or ingestion of a particular food. And it's important to note, food allergy occurs typically within 4 hours of ingestion and is typically very consistent and reproducible. That is to say, if you ate something for dinner, let's say 8 p.m., you're fine, you go to bed, let's say 11 p.m., and then you wake up at 6 a.m. While you're brushing your teeth, you notice you start getting hives. Then you quickly go back and you're going back in time. You're like, oh my gosh, maybe I'm allergic to what I had for dinner. Well, at this point, we're almost 12 hours out from dinner, so unlikely to be an allergic reaction, right? Because what you would have been allergic to is past food allergy is what we call an acute reaction. So over 4 to 5 hours is past that time frame where we'll call it allergic. So we'd look for other causes. And also, consistent and reproducible, meaning if on Monday you eat a particular food and you get hives, and you just so happen to get hives, maybe Thursday you try it again and you don't get hives, and then you're like, man, sometimes I get hives and sometimes it's around shellfish and sometimes it's not. Then it's unlikely to be a food allergy, because food allergy is one thing it is not. It is consistent and reproducible. So please keep that in mind. So let's talk about some top 9 food allergens. So it used to be what we call the big 8, but sesame has recently entered the chat. So now our top 9 food allergens include peanuts, tree nuts, egg milk, wheat, soy, fish, shellfish, and sesame. It's important to note that tree nuts and peanuts are not the same. So peanut is a legume versus tree nuts are actual nuts. Coconut, also a misnomer, it is actually not a nut, contrary to the name, it's actually a seed. So it's important to note that, because there are people who are unnecessarily avoiding peanut because they're allergic to other nuts, or unnecessarily avoiding coconut. So it's important to properly categorize those things so that you're not avoiding anything unnecessarily. So let's talk about food intolerance then, and how it differs from food allergy. Well, first of all, food intolerance is not IgE mediated. So remember that allergy cell we talked about? It's not related to that. It's non-IgE mediated adverse food reaction, and most adverse food reactions fall into this category. So examples include lactose intolerant, gluten sensitivity, and then something called food protein induced enterocolitis. That is a mouthful, but you just call it FPIES. And really what that is it's an adverse food reaction where all you have is gastrointestinal stuff. So you have repeated vomiting, diarrhea, or both. And what sends these people to the emergency room is typically the dehydration. So with the FPIES, you don't get throat closing or lip or tongue swelling. You just get lots of GI things, and it tends to happen in toddlers, and typically goes away by school age. So let's talk about some common symptoms of how you can tell the difference between food intolerance and food allergy. Food allergy has symptoms such as mouth itching, hives, vomiting, throat tightness, lip or tongue swelling, anaphylaxis, shortness of breath, that type of thing. Now, anaphylaxis comes in when you have 2 or more of those symptoms together. We like to call it when you have 2 or more body systems involved, like, vomiting and hives, tongue swelling, shortness of breath. Those are 2 symptoms or 2 systems that qualifies as anaphylaxis. So give, administer EpiPen and go to the emergency room. Now let's talk about food intolerance. Food intolerance then is mostly gastrointestinal. It's mostly discomfort, right? Bloating, belly pain, diarrhea. Notice you don't have anything like throat tightness, difficulty breathing, the hives, that type of thing. That's not present in food intolerance. So we're back to some key points again. So when we talk about food allergy, remember, food allergy is driven by a cell called IgE, while food intolerance or sensitivity is not. And remember, food sensitivity does not equal food allergy. And very important, no matter what it is, no matter if it's intolerance or allergy, if a food causes you discomfort, it's recommended that you avoid it. Never mind why it causes you discomfort. you should avoid it because your body's telling you, hey, I don't like this. And much like a relationship, if your significant other says, I don't like this, honey, it's important for you to not stop it. Our relationship with our bodies is the same. Our body will let you know what you don't like, and your job is to listen to it. So let's talk about another adverse food reaction called oral allergy syndrome, which a lot of people might have noticed but didn't know the name. What is oral allergy syndrome really? Oral allergy syndrome is what I like to call a case of mistaken identity. In a medical world, we call that molecular mimicry. Excuse me. Sorry about that. Getting over a cold. So, some food allergens have some proteins that are similar to environmental allergens. That is to say, something like birch pollen. Sometimes when you eat a certain food, your body thinks it's birch pollen because molecularly it looks the same. So you eat it, and your body's like, oh no, she's eating birch pollen. And then what it responds with local itching. So your mouth itches, maybe you get some swelling around your lips, that type of thing. Now those proteins are very what we call labile. That is to say, they can get changed very easily. So if you heat it, you process it, like you turn the apple into applesauce, things like that. You now change the molecularly makeup, so you change how it looks. So now when you eat it, your body's like, oh, just kidding, that's apple, or that's peaches. Never mind, it's not birch pollen, and then you can avoid that itching. Symptoms do tend to be worse during whatever that allergic season is. That is to say, if you're allergic to birch pollen, your OAS symptoms will be worse during the season where birch pollen tend to be out. That's not to say it's the only time you'll have it, it just tends to be worse at that time. So this is just a visual representation of the symptoms, mouth itching, tingling, hives, scratchy throat. You can get some swelling of the lips, tongue, and throat, but less than 5% of people with OAS get those throat symptoms, that throat swelling. It's less common. Also, remember the main difference is, hey, I, for some reason, can't have peaches if I eat them fresh. But I peach cobbler, I'm fine. I can't have apples if I eat them fresh or if I go apple picking. But if I do applesauce, I'm fine. Sorry, guys. So this is just a representation of the different pollens that are associated with certain foods. Excuse me. So things like peach, pear, plum are related to birch pollen, kiwi, grass pollen, and ragweed, which is in the fall, but it is some melon. Oh, sorry. Ooh. My goodness. So it's important to note that you don't typically react with all of the pollens. You typically react to some of them. So just because cherry and kiwi and peach is part of the birch doesn't mean you're going to react to all, cherry and peach and birch and plum. So let's go back to food allergy. So we talked about adverse food reactions, we talked about food allergy. So let's talk about, how do you know when you're supposed to see an allergist? You're like, okay, is it OAS? Is it adverse food reaction? Well, first of all, make sure you note your food trigger. Is it reproducible? Is it not? And then discuss with your doctor. You may have an adverse food reaction, and an allergist is not the right subspecialist to see. So talk to your doctor, tell them your exact concerns, and with your doctor, you can determine the appropriate specialist to see. Ooh, sorry, guys. Okay, so in talking about when to see the allergist, let's talk about what to do when hey, you made an appointment with an allergist. We determined that this is the right place, a person for you to see. How do you get ready to see your allergist? First, you want to make sure that you know any reproducible food reactions. Hey, this is what happens when I eat this food. This is when it happens. Timeline's very important. When did you first notice this happening? How long after you eat the food does it happen? When was your last reaction? That's important because, a lot of people will say, hey, I had a reaction, yesterday. This is the right time to go to allergist. But actually, we'll talk a little bit later why it's important to actually wait a little bit longer before you see the allergist. And then you have to, you want to make note of how long have you been avoiding that food, right? So it's like, okay, well, does the reaction still happen even if you still avoid that food? So it's important to know. And then note pertinent family history. We have family history of allergic diseases, not just food allergies, but other allergic diseases. Sorry, I'll get it together. So let's talk about food allergy testing. There's 3 types: skin test, blood test, and oral challenges. So when we talk about testing, oral food challenge is the gold standard. So what does oral food challenge mean? That means you go into the office in a supervised setting, you'll eat the food, and they'll monitor you. Ooh, so that typically takes at least 2 hours, because what you'll do is you'll eat a little bit of the food, they'll wait 30 minutes, you eat a little bit more of the food, that type of thing. But that's a gold standard, because no matter what testing says, if you eat the food and you're fine, then you're fine. So when we talk about, when we jump into talking about testing, panel testing is the bane of our existence. It is highly discouraged. Let's talk about panel testing mean. Panel testing means, I notice that I'm bloated all the time. I'm not sure if I'm allergic to particular food. Why don't we test for everything and just see what pops up? You don't want to do that, because that then can bring a lot of false positives, and that leads to, eliminating things that you don't need to eliminate, which can lead to malnutrition. You want to base your test based on clinical history. So you take a diet history, say what's reproducible, what's consistent, like, hey, consistently, if I eat this, I have a problem. And then you can test that. And then blindly eliminating food diets. You don't want to just, hey, I'm going to eliminate these, however many foods. It can lead to malnutrition. You want to make sure that that's a conversation you have, and make sure that there's a reason and you've noticed something reproducible that happens. And then when it comes to children, early exposure is key, because you want to make sure that you impose tolerance on that. When you early expose kids to something like peanuts, that type of thing, that helps improve tolerance, and helps them to be able to have a varied diet, because the more you avoid it, the increased chance that they'll have an allergic reaction. So when we talk about skin testing, remember earlier I mentioned, hey, if you had a reaction, make sure that you wait for a little bit before you go see the allergist. So that's because of this rule right here. So anytime you have a reaction, you have to wait 6 weeks or more after the suspected reaction before doing testing, because that's because the cells that cause that reaction, what they secrete is what we test. And when you do that too quickly, those little things that they secrete are still replenishing. And because of that, you'll have a false negative on your skin test. So if you have a reaction, you want to wait 6 weeks from that reaction at least before you get skin tested. So let's talk about the treatment of allergic reactions. So for allergic reactions, the most important thing is to avoid, and then avoid some more. So let's talk about avoidance, and what that means in terms of, your social life, and, dietary practices and things like that. Well, Allergy Asthma Network, of course, has a great part of their website that tells you, living with food allergies. They give you guidance based on the child's age, that type of thing. What we call Quad AI, it's AAAI.org, helps, also give you some tips on guidance on safe dietary practices and things like that. That could really help you with avoidance, help you on just kind of tips on how to better manage and live with your food allergies. Now, it's very important. This part is very important. If you have a food allergy, that equals carrying an EpiPen. A lot of individuals think that if you don't have a history of anaphylaxis, you don't need to have an EpiPen. That's not true. Having a history of food allergies increases your risk of having an anaphylactic reaction. Therefore, you should have an EpiPen. So, in talking about treatment for food allergies, let's talk about food allergy action plan. When you have a food allergy, you should have something called a food allergy action plan. What is that? What that is a form completed by your doctor that helps guide you as to what to do when to do it. Mild symptoms, it tells you what to do. See here, it tells you, okay, these are what considered mild symptoms, is what you do. This is what you should take. Here are severe symptoms, is what you should do. This is what you should take. Now, you want to make sure you talk to, it's an individualized plan. So you talk to your doctor and they fill this out and you have this with you so you know what to do. Interestingly enough, when we talk about disparities, research has shown that more white children have been given food allergies action plans than African American children. So remember that study I talked about earlier, the forward study? Well, it showed that, hey, a lot of African American children aren't actually even given this food allergy action plan, which they should. That's standard of care. Sorry, guys, my nose. Let's talk about immunotherapy. When we talk about treatments, let's talk about immunotherapy because that's important coming down the pipeline. Sorry about that. So we're talking about immunotherapy coming down the pipeline. There's a lot of cures, not cures, but treatments coming up. So first and foremost, let's talk about palforzia. That is the part of this that doesn't include anything but oral. So what that is just a capsule that has a little bit of peanut powder in it. And it's for ages 4 to 17 years, but you have to take it every single day. And that's where things get into, because you have to do some dose changes when you miss a dose, that type of thing. So it is right here when you see, hopefully you can see my mouse. So it's these little pills, you take them every day and you make sure you stay on top of it. So there's currently no cure for food allergies. All the treatment I'm about to talk about are ways to mitigate your food allergy. Nothing can cure your food allergy, but they'll mitigate it, maybe decrease how much it takes for you to have, a severe reaction, that type of thing. To that end, let's talk about Xolair. It was recently approved for food allergies, and it's approved for 1 year old and older. So here we were talking about 4 to 17 years. Now it's approved for even more people, right? Because now you can go down as far as 1 year old, and you can go with multiple food allergies, whereas palforzia is just for peanuts. It's an injection that decreases the likelihood of having a reaction. These are what the injections look like. So in one study, they found people could consume 600 milligrams of peanuts, and that's the peanut side, and then the other amounts that you can ingest of cashews, eggs, and milk, that type of thing, you can ingest more before you get any reactions. And then you take the injection every 2 to 4 weeks for 16 to 20 weeks, right? So again, there's no like one-stop shop, give me the shot, I'm cured, I'm good. There is, everything takes dedication that's currently out right now. Now, this is still being studied, but there's the patch. It's called epicutaneous immunotherapy, or EPIT for short. Researchers are still evaluating it, but it's this Viskin patch technology. So what it does is there's the patch, which you see here, it has different layers, and it contains literally a tiny amount, micrograms of an allergen. And currently there's one for peanut, being studied for peanut, there's one for milk. And there's these little cells on your skin that surveillance your skin to see what they don't like. And the patch goes on top, and those cells react to it, and it helps induce modulate your immune system. So they're clinical trials that are FDA approved yet, but it's coming down the pipeline. So now let's jump into reading labels, right? Hey, I know I have a food allergy, I want to have a social life, but I want to be more aware on, how do I read lead labels? Well, be aware that there are a number of aliases for different food allergens. We'll talk about them in the next slide. Let's talk about highly refined oils. Chick-fil-A comes to mind because they use highly refined peanut oil. They separate that particular process separates the protein, which is the allergic part, from the oil. So highly refined peanut oil, tree nut oil, that type of thing. So companies will not be, if you use highly refined peanut oil, you're not required to then list peanut or anything like that on the labels. Typically, you're fine to ingest it. But if you're worried, just avoid it, right? When in doubt, leave it out. So let's talk about what we call the hide and seek of food allergens. These are just different names that they could come under. So casein for milk, albumin for egg, legumes. There's tahini for sesame, that type of thing. So just be aware that there are different names that could come, especially if you're traveling, things like that. The way that things are labeled in another country may be different, so you want to be aware of some common alternate names for different allergens. So let's just, we're going to finish off talking about some resources. So resources for food allergies, we'll talk the Living with Food Allergies you'll get from Asthma Allergy Network. They have back to school checklists like you see here. That's going to be really, really helpful, especially if your child just got diagnosed with food allergy, your head's spinning, you're like, oh my gosh, food's about to be open. Are they good? Are they safe? How do I make sure? You can go to the Allergy Asthma Network website. It'll help, talk you through these checklists to make sure you have dot your I's and cross your T's. It talks to you about food insecurities on that website, some resources to help with costs, both state and nationwide. And let's talk about the Food Allergy Research and Education website, the foodallergy.org. It helps you talk about, it gives you tips on how to avoid cross-contamination, how to read labels, preparing others to take care of your children with food allergies. That's important. Support groups and stuff like that. Let's jump and talk about food insecurities and resources. Can't have a lecture talking about health disparities if we don't talk about food insecurity and what it is. Food insecurity is, the definition of that is really a limited access to good quality of food and or the good quantity of food. Now, how to combat that? There's various resources. Allergy Asthma Network, again, has ideas of how to help with food costs, but fooddiversity.org is a great resource. They have a network that includes physicians, food pantries, school nurses, and what they do is they connect individuals or families with consistent, reliable sources for food allergy friendly foods, or I'm sorry, food allergy safe foods. They also have education materials and support system. And some, they may even provide gift cards. Don't quote me, but I think they may even give you gift cards. This is one of their programs that they've done too. So there's resources out there. The Food Equality Initiative, I won't spend too much time on it, but just know Emily Brown is the founder of FEI and does amazing work, really helping to provide those diagnosed with food allergies and other diseases, access to quality foods, despite, regardless of their, race, geographic location, economic status. Really, they're just championing championing the fight for nutrition security and health equity. So when they first start off with the Food Equality Initiative, to help combat, access, education, and advocacy, the problem is it was mostly around the Kansas area. However, enter the chat Free From Market. So the Free From Market is an online platform where you can order your food based on your condition for, diabetes, maternal health, food allergy, high cholesterol, hypertension, that type of thing. And that's for individuals outside of the Kansas area. So they have over 1,500 nutrient-dense foods. You can sort them based on your ingredient, health condition, price, or brand. So what you do is you go to the website, you start shopping, and then you can go and make an account. Ta-da! They also had telehealth coaching and nutrition, but that helps access to food allergy, allergy-friendly foods. So let's talk about where we've been. First of all, hopefully it wasn't as windy as this picture, but I won't read this whole list to you, but recall, we've talked about, some food disparities, some stats, burdens of food allergy, understanding food allergy versus adverse food reactions, knowing when to see an allergist, preparing for that allergist visit, and really understanding what treatments are out there, what resources are out there to help you get access to foods that are safe for you if you have food allergies, and resources to help you with some costs. So I really hope that that's at least really helped you with either if you have food allergies or have a loved one with food allergies, really help arm you with empower you with some knowledge today. So with that, I'll move it on to Mr. Thomas Silvera. And I'll stop sharing my screen.
Okay. Thank you, Dr. Joseph.
Sorry about all that coughing, guys. I'm trying to get better with my cough, but I'm on the mend.
You did great. It was very informative, and I really am glad that you kind of honed in on the difference between food tolerance and food allergy, because it's a big difference. So Thanks very much for the information. So now I'd like to introduce you to Thomas Silvera, who will also share his story about food allergies. Thomas is the CEO and co-founder of the Elijah Alavi Foundation. He is a certified surgical technologist and public health advocate with a Master of Science in Public Health and is currently pursuing a doctoral degree. Thomas is a tireless advocate for public health regarding food allergies and asthma, particularly in childcare and daycare centers. He played a crucial role in the passing of Elijah's Law in New York, which was signed into law on September 12th, 2019. That's awesome. This law was named after Thomas's son, Elijah Silvera, and was a major milestone in the fight for improved health and safety in child care centers across New York. More recently, Thomas played a key role in the passing of Elijah's Law in Illinois and Virginia. Thomas's ultimate goal is to implement Elijah's Law in every state and eventually nationally, making a significant impact in the lives of children and families across the country. Thomas, thank you so much for being here. I can't wait to hear your story.
Yeah, thank you so much for having me. I think we need more of these type of webinars to kind of be highlighted and shared within the community. Thank you to AAN, thank you to Genentech, thank you for everyone being here and taking the time out of your busy schedule to hear our stories and to find out what we can do as a person, as an individual, or as a community to create change. So just to give you a little background about who I am, Thomas Silvera, I'm the CEO, co-founder of the Allergy Asthma Foundation. We started this foundation because of the loss of my son, Elijah Alavi. On November 3rd, 2017, my youngest son, Elijah, came to a tragic demise while he was attending his childcare center in New York City. You know, my wife and I at the time, we made sure that we provided all the necessary information for the school that we had chosen, a school that we were given the information that they that we obtained to state that this was a school that understands children with multiple disabilities, especially food allergies, and gave us peace of mind. So not even his first week of school, an educator had fed him a grilled cheese sandwich. Them even knowing he had a severe allergy to dairy and did not give him his specified meal, had caused my son to go into anaphylactic shock. And upon my findings afterwards, they failed to tell his mother what they had given him. We had to wait a couple days later to find out that they actually gave it to him. So we decided to channel our grief instead of being angry and just, you know, burying ourselves underneath our covers. We decided to create change. And that change is the Elijah Alavi Foundation and creating legislation and advocating for so many children with food allergies, especially in childcare centers. One of the biggest thing about childcare centers, children have their very first reaction in childcare centers. We're talking about from 0 to 4, you know, in those spaces, and they have their first reaction. Just imagine that stressor of not knowing your child having a food allergy, and your child is at a childcare center that does not know how to provide the adequate care or act in the event of emergency to administer epinephrine. That's one of the most scariest things. With my childcare center we chose for Elijah, they had assured us that they were that top tier type childcare center, which they failed us. Give you a little backstory about me. I am also a parent with food allergies. I have another son, Sebastian, who has multiple food allergies. And in the beginning of finding out about my son, Sebastian, we didn't live in the best neighborhood. We were in the underserved community, a middle-class family living in an underserved community, because in New York City, it's hard to afford rent there. So one of the things, you know, what we did when we found out our youngest son had food allergies, we took him to his primary care physician. It was unfortunate because it's like, okay, he can't have this. Here's an EpiPen. See you on your way. It's almost like that mama bear, it's like the the mother bird syndrome. It's like, here you go, we'll push you off the tree branch and let you fly. Can't do that. So we had to kind of like do our own research and find an allergist. And then in specific communities, finding an allergist is a financial burden. It's very costly. It's not provided by your insurance. You have to go outside of your network to pay for that added cost. And also getting epinephrine at that time with one child was an added cost. Here comes Elijah. Elijah had multiple food allergies. Believe Elijah had more than 10 food allergies. And we had the burden of having two children with food allergies and Elijah also having asthma at the same time. It was quite cumbersome. So it was one of those things we were shaking our head as parents. And when we talk about mental health, the mental health aspects, it's like how we as parents are going to be able to afford the adequate care for our children, even with the affordable health care, because we have to go outside of network in order to obtain an allergist that can actually help them. It's like, even with a good job that I had and mother having, it's still a financial burden. Epinephrine, carrying epinephrine, not just in our house, in school, in a backpack, we each had to carry epinephrine if we had a child. So implication. Then it comes to changing everything that you eat in your home in order to keep these children safe. So it's a financial burden. It's a mental health stressor because we need to keep our children safe. And I say this, it's like, it may seem overwhelming to some people, but this is what we do as parents to keep our children safe. The love and everything is there for them. No doubt about it, it's there. But living in the specific community, predominantly Black and Hispanic, I noticed one thing: the access to healthcare, the access to providing food allergy management was not there. Again, we took our children to emergency room. The emergency room did not provide action plans, didn't say, hey, go follow up, just follow up with your primary care physician, which is given. Emergency, they're supposed to treat, but there was no information given to us. It's always like you had to pretty much do the research on your own. So it's one of the burdens that we face in the community that we live in. There's no education, the access to healthcare, the disparity aspects of that. To go to a clinic is miles away from your actual primary care physician. It's cumbersome. And I move forward in my life, and his life is getting better, but I'm still grieving. I'm still in pain. And I still have to provide the adequate care for my other son in his middle school, making sure that the educators are equipped with understanding food allergies, how to mitigate risk, how to understand his food labeling. Even though my son Sebastian brings his own food, he still has to be mindful of what an educator may give him without, as he advocates for himself, he's also being responsible to make sure he educates the educator that he is not allowed to have specific foods. So it's another thing that we have to keep doing until he gets to a certain point in his life where he can actually be individually on his own to start making these necessary changes. So it's still scary for me as a parent. I believe that it is for everyone else. It's a stressor that I receive every single day, especially even seeing a phone call or an email from his school. It's challenging for me. It's anxiety driven. It's like, I see a therapist, not just for my grief, but also to deal with all the stresses of life, and also talking about how to manage things with my son. It's one of those things I want to, I keep doing to make things better. But I can tell you this as a patient advocate dedicated to improving the lives of children with food allergies, particularly in the Black and Hispanic community. I just want to highlight, like, one of the critical barriers that needs our immediate attention and our collective action is a stark need for enhancing awareness, the education aspects about food allergies, because we all know that knowledge is power, and in allowing this information to giving the resources to the community makes a world of a difference, and also helps them to recognize the signs and symptoms and how to mitigate, when they find out they have a food allergy. When it comes to talking with their primary care physicians and giving them better understanding, because a lot of people in the specific communities are being misdiagnosed. Some are going with a lot of GI issues, stomach issues, when the underlying issue can actually be an allergic reaction. And it's one of those things that I've heard several times, and it's not like until like maybe a month or two later when something severe happens that that child who went in with a stomach issue with vomiting and diarrhea comes to find out they have a severe food allergy, but their diagnosis was missed. And that's so unfortunate. So having the right access to healthcare is another significant challenge that we need to address in the community, especially as, when it comes to struggling with affordability, the availability for specialized care. Like this is just not about having health insurance or free health insurance. It's about having access to an allergist and a facility equipped with to handle severe allergies, and where this is something that we must advocate for when it comes to working on policies. And that's one of the things that I strongly work on, is working on public policies, especially like Elijah's Law, to make sure we can provide this adequate care to specific communities. And the cultural competency is one of the things in healthcare that we cannot overlook. And I think if you look at your healthcare providers, there needs to be a need to understand and respect the cultural practices and the influences when we talk about the dietary habits, or when it comes to the crucial management of food allergies. So I see that as one of the most vital things to address, and the underrepresented of the Black in the Black community, and when it comes to food allergy research, is not there. And I think, which was highlighted, that there needs to be more research when it comes to the access of food allergy management and healthcare access when it comes to the Black community. We are not being put into research as much because if you look at the statistics, the numbers are irrelevant. So we need to actually go into these communities and get those findings and those numbers. So hopefully I hope that wasn't a mouthful, and I hope you guys can grasp onto what I was saying and get an understanding of that. But this is what I do. This has become my life work. And I want to make sure that I can continue doing this going forward, fighting for everyone who has food allergies, especially in the Black and Hispanic communities.
Wow. Thomas, thank you so much for sharing your story. Trying not to get filled up, but I am, because it is so important. And you're right. I agree with you as far as the education, the research, the awareness in the Black community is just not there. Because, people might say, oh, I ate this and it just didn't agree with me. I just won't eat it anymore. And really, it could be a severe food allergy. So a lot of awareness has to be done in those both Hispanic and the African American community. So thank you. So sorry for your loss, and I just appreciate you being here and just being courageous enough to take what you've gone through and make something positive out of it. So thank you.
I appreciate you. Thank you.
Yep. So I am going to, excuse me, run through research studies and talk to you just very briefly, because I want to make sure we have enough time for questions. So what is a clinical trial? Clinical research is really a branch of healthcare. It could be viewed as a treatment option as well. And it's really science that determines how safe and how effective a medication or your device meaning, you could have a stent in your heart or a pacemaker. That's what I mean by device. And then the treatment regimens intended for human use. So it really helps doctors and researchers to find new and better ways to understand and detect and control and treat illnesses. So some of the benefits in participating in clinical trials is access to new treatments. So some of the newest, most innovative treatments are available only through clinical trials. For example, our understanding of cancer has evolved greatly. We have so much out there now to treat cancer. And then contribution to medical knowledge. Clinical trials, it's a really exciting opportunity actually to contribute to science and pave the way for future discovery. So I always hear from patients, they want to help others with the same disease and what they're going through. And one of the ways that they can do that is being part of a clinical trial. We just don't have enough diversity representation. One example that I can think of, way back when there was a high blood pressure study done for African-American men, and they were studying two different drugs, and one affected them better than the other. So because of that study, and it's because of the DNA and the way that they were wired, they responded differently. So those are the kinds of things and the reasons why it's so important to have diversity, because we're all different. We have different lifestyles. So let's talk a little bit about the diversity, why it's important. I just mentioned to you that, you know, some people experience diseases differently. We have different social determinants of health are different for everybody. And diverse clinical trial participants help researchers really understand how safely the drug works for those different populations. And, you know, in the African-American community, we make up about 13% of the US population, but only 7% gets involved in clinical trials. So there's a lot of education. There's a lot of rewiring and resetting the minds of people who think clinical trials are just so bad. A lot of education that needs to go there. But it really also helps to understand the patterns of differences in health and illnesses based on, you know, different backgrounds. So that's all that I have for that. Now, do we have the question and answer? Yeah, we're going to go into the question and answers now. So Dr. Joseph and Thomas, if you want to come back on the screen. Let's see what questions we have in the chat here. Okay. So this one, excuse me, I guess it could be, this is for Dr. Joseph. Can you talk more about anxiety and food allergy? Can children and adults have PTSD from fear of anaphylaxis?
So there's a complicated answer and there's a simple answer. So the complication comes in with the term PTSD, right? Because that's something that's, you know, typically clinically diagnosed by psychiatry, that type of thing. So, but it is colloquially used to say, you know, there's a level of food-related anxiety, which is what I was talking about, secondary to having a reaction. So I will address it based on the food-related anxiety as opposed to using the term PTSD, because again, that's, I guess from my perspective, that's more of a, clinical diagnosis, that type of thing. But if we're talking about, right, there's research that does show that children with food allergies do have, can have increased tendency of having food-related anxiety. Additionally, we talked about how mothers of preschoolers with food allergy have increased stress and increased hypertension. So the answer to your question, the simple answer is yes. The only complication is, you know, when we talk about the particular diagnosis of PTSD, we want to be careful with that term, because, you know, it's a particular term diagnosed by, psychiatrists. But if we're talking about, hey, someone with food allergies tend to have increased risk or increased, that study did show there's increased, panic attacks and anxiety, but in general, there is an increased incidence of food-related anxiety, especially if you've had a history of severe reaction.
Okay. Another question for you, Dr. Joseph. My 10-year-old child's allergist didn't want to consider Xolair. Are there reasons this would not be an option?
So the answer is there is also a reason why someone may not be a candidate for any particular treatment, right? Because any treatment has to be, though it's, any treatment that I've talked about, there's, anytime you see anything on TV or anything like that, it's always like, ask your doctor, right? Because there may be something, a condition, something, a medical history that then makes it what we call contraindicated for that thing to for you to be able to get that treatment. So not knowing, the complete health history, obviously the pediatrician knows that, or the allergist knows the complete health history. I don't know if there's a contraindication, but the short answer is, with any treatment, there may be contraindications that keeps you from getting that treatment. When you have that in place, you can't get that treatment. So that may be the reason. I obviously cannot speak to why that physician does not want to, or why that particular child does not qualify for, that would be between you and your physician. But certainly you're welcome to ask more questions. Hey, why doesn't he qualify for that? Why can't we do that? To have a, a shared decision-making approach for sure.
Okay, so good lead in, because this could be for both Thomas and you, Dr. Joseph. Any tips for how families can have conversations with their doctors that allows for shared decision making?
I'll let, actually, I'll let Mr. Silvera go first, actually.
Oh, sure. Can you repeat that question again?
Yep. So are there any tips for how families can have conversations with their doctors that allows for shared decision making? And then another part to that question is, how can I have a better conversation with our doctors without feeling, without them feeling we're challenging their authority?
Here's the thing, me as a parent, when it comes to addressing my child's primary care physician, the one thing you want to go in there honestly about everything. You want to be open about everything that's going on in your child's life. Um, don't hide anything, don't brush anything under the rug. If something is affecting your child, make sure you address that. If you want to share a decision, you want to come to one of those things. It's like when you're addressing all the things that are affecting your child with food allergies, make sure they're going to point you into the right direction. Make sure you come to an understanding and ask questions where they're going to be able to answer them. Ask for, make sure, how do I get a food allergy action plan? Where do I do this? Where do I get that? Ask for vital resources. You want to make sure you get your resources, because sometimes your primary care physicians don't have the information, but you can go outside of that and look for factual resources. And the main thing you want to do is get factual resources from credible places like like ANN, you got FAIR, you have so many other organizations that can give you that resources. But to go in, you want to make sure that you don't feel like you're overburdening that physician, because you have your child's life in your own hand, and then everybody else has to make sure they can add that added protection. So you rely on that physician to make sure you both can come to consensus of how to have a better food allergy management for your child. So make sure you come in there with your notebook with every question you want to ask, so they can understand where you're at and how they can work with you on that. That's just my perspective.
Okay. Thank you. Dr. Joseph, you want to add anything to that, or?
Yeah, so a couple of things. Two things to keep in mind when we talk about your, physician relationship. One, it's a relationship, right? So one, just like you don't want to be uncomfortable in a relationship with your partner, you don't want to be uncomfortable in a relationship with your doctor, right? So the doctor relationship is not an authoritative one. That is to say, it is not a relationship in which you come in, I tell you what to do, you leave. It's an information exchange. And what I recommend to patient A may be different than patient B. Not, again, standard of care all across the board, right? But you may not be able to, your insurance is different. Maybe there's two options for that treatment, but option A doesn't work for you, but option B does. And then the next person, option B works, option A doesn't, right? So it's an art-based individual, it's an individualized situation. That's one. So your relationship, you should be comfortable with your doctor to where you can say, hey, this is why I'm a little concerned. This is why I don't want to do this treatment that you want me to do. And then we can talk about, hey, I understand your concerns, and maybe I can address those concerns to where you're now like, okay, this is fine. So that's one, that's my short answer for the relationship aspect. Now, when we talk about going in, one thing I didn't put about like getting prepared for the allergist, understand that if you have 15 things you want to discuss, unlikely that we'll be able to discuss 15 things. Very unlikely. But you can, I would say, listen, here's my top 3 concerns. Like if I go out of this office without getting clarity in these things, it's going to bother me. I would say keep those things in mind, because you don't want to get sidetracked with all these other things. And then you come out, what did she say? Honey, so when you want to come in, you want to say, okay, kind of like, when you go to your meetings at work and you have your, this is what I want to make sure I take care of. This is what we want to make sure we get in today. Here are my top 3 concerns. Hey, I'm concerned he or she has a food allergy. I'm concerned about early introduction because of the this and this, and I'm concerned that there's no treatment options, or whatever the case may be. and you want to make sure that those are addressed. Now, because other things, because you don't want to bombard yourself, right? Because with every question, I have an answer, and then you don't want to bombard yourself with info, but you want to make sure that we have a very time efficient and effective conversation and visit so that you come out there feeling empowered with knowledge and like there's a good exchange in the relationship.
Okay. I think we got time for one more question. Please comment on families using Benadryl to avoid foods instead of epi. Is it related to lack of access to quality healthcare?
Oh,
To Benadryl to avoid foods? What do you mean? You said
I'm not sure.
Does the question say Benadryl to avoid foods or treat food
I
allergy reaction?
think I'm interpreting it if instead of using an EpiPen, use Benadryl. If they have a reaction or something to a food, they'll take Benadryl instead of epi. And is that kind of related to access of quality healthcare or even an EpiPen?
So
That's my interpretation. I'm not sure.
Gotcha. So access means I don't have what are we not? Well, you're saying sounds like you're saying no access to EpiPen. So two things. Number one, we try to shy away from Benadryl, although it's frequently used, but we try to use something like a Zyrtec instead. Why? It's because Benadryl is short acting, makes you groggy. Zyrtec doesn't make you as groggy, is that equally as effective, less side effects, etc. So that's one thing. Second, remember I talked about that food allergy action plan. There
Yeah.
is a role for an antihistamine with food allergy action plan, such as, Zyrtec. There's a role for that. There's a role for antihistamine in EpiPen. There's a role for antihistamine EpiPen emergency room. There's a role for all of that. Now, a blanket question of whether, let's say you're using an antihistamine to treat your allergic reaction, and if the question is that appropriate? The answer is it depends. Because there are times that even as a physician, all they need is just an antihistamine. There are also times when they need an EpiPen. And which times those are is dependent upon what's happening, the patient, and that's where the action plan comes. So I can't speak to if they're using that for an anaphylaxis treatment, I can't speak to that. But if the short answer is antihistamine is part of a plan to treat food allergy reaction, but mild reactions.
Okay. All right. Well, thank you.
Actually, Catherine, can I address something? Because I don't know if it was in the chat. And
Okay.
I answered it, but I don't know if someone had asked a question about oral allergy syndrome, and they had asked, hey, I have oral allergy syndrome. I'm on immunotherapy. I'm assuming you mean allergy shots. And something happened. It looks like you were on allergy shots, and then something happened where you had a reaction again. I'll just say two simple things. One, when it comes to allergy shots, they can help with your symptom of oral allergy syndrome. That's one. Two, when you're on allergy shots and you have that build-up period where you're on it more frequently, and then you build up, and then you're on it monthly for a particular period of time. Once you stop taking it, once you are taking it weekly, and you get to your constant dose that you're going to be taking every month for the next 3 years, you have to be on that constant dose for at least a year to get maximum benefit. That is to say, you haven't reached a promised land just because you're like, oh, I'm off of buildup now. That promised land's not reached until you've been on like my consistent top dose for a year. That's when you may still get the symptoms. We're not at that promised land yet. So that might be if we're asking, hey, why is my OAS not to my liking yet? That might, if that's what you're asking, that may be the reason. You were gonna say something, Mr. Silvera? Sorry. I hope that helps. I'm sorry if we didn't get to your question. I'm so sorry. I apologize. I know we're
Okay.
over time and we want to be respectful of people's time. Otherwise, we'll be here till 7 p.m. Eastern time.
Yeah, we are out of time, and I just want to thank everyone who attended our presentation today, and special thanks to you, Dr. Joseph, and to you, Thomas, for sharing your story. And I hope everyone is able to take away some learnings from today's webinar. I know that I will. You're going to receive an email in a few days with a link to the recording and evaluation and additional food allergy resources. So please be sure to complete the evaluation for today's presentation, because your feedback really helps us to be better and give you the things that you need to live a better allergy life. So thank you again from all of us at the Allergy and Asthma Network, and join us as we work every day to breathe better together. Thank you and have a good evening, everyone.
Thank you, everyone. Thank you.
Thank you, everyone.
Bye-bye.
Bye-bye.